Welcome to Weekly Neurology Deep Dive. We're here to help busy neurologists like you stay up to date
Yeah,
on the latest neurology research.
that's right.
This week's deep dive is purely educational.
Yeah.
No commercial interest here at all. We will be summarizing a study on a potential new biomarker published in Neurology, Neuroimmunology and Neuroinflammation. Of course, as always, you'll need to read the full paper to get all the juicy details.
Absolutely. The study investigates a potential biomarker that can help us differentiate a few conditions:
So,
multiple sclerosis,
in,
myelin oligodendrocyte glycoprotein antibody-associated disease,
right?
or MOGAD,
Oh, God.
and neuromyelitis optica spectrum disorder, NMOSD,
Okay.
all in patients presenting with inaugural optic neuritis, ION.
So this is about helping us figure out which of these conditions is most likely in a patient who comes in with their first episode of optic neuritis.
Exactly.
Tell me more about this study.
So researchers at the MS Center of the University Hospital of Marseille looked back at data from 210 adults admitted for ION between March 2016 and April 2024. All patients had a lumbar puncture for CSF analysis.
Cerebrospinal fluid.
Yes, including measurement of the Kappa free light chain index.
Let's talk about that KFLC index. For those of us who don't use it every day, remind me what this is and why it might be relevant in this scenario.
The KFLC index measures the ratio of Kappa free light chains in the CSF to those in the blood serum. It's been gaining attention as a potential biomarker for MS because it can reflect the production of antibodies within the central nervous system.
And that's important because in conditions like MS, the immune system is attacking the nervous system.
Precisely. The researchers wanted to see if this KFLC index could help distinguish between MS, MOCOD, and NMOSD, which can all present with ION. They compared KFLC index values across patients with final diagnoses based on established criteria for each condition.
And what did they find?
The study found that a KFLC index below 4.9 differentiated MOCOD from other diagnoses with 92% sensitivity and 63% specificity.
So if I'm understanding this correctly, in a patient presenting with ION, a low KFLC index makes MOGAD more likely. How often did that happen in this study?
Out of the 210 patients, 93,
Okay.
or 44%, had a KFLC index below 4.9. Of those patients, 26% had positive serum anti-MOG antibody testing. Confirming the diagnosis of MOGAD, this suggests that the KFLC index could be a useful tool for us to decide which patients need MOG antibody testing.
That could be really helpful, especially since MOGAD often requires a different treatment approach than MS.
Absolutely. Being able to differentiate between them early on can lead to more effective care.
So how does the KFLC index compare to the tools we already use? For diagnosing these conditions, we often order tests like oligoclonal bands
OCBs.
in the CSF.
You're right. However, OCB testing can be more time-consuming,
Right.
and results can vary between labs. In this study, the KFLC index performed similarly to OCBs in terms of accuracy for differentiating MS from MOGAD, but the results are available much faster.
That sounds promising. Faster results with similar accuracy would be a win. Does this mean we should be ordering this test for every patient with ION?
It's certainly worth considering. The KFLC index could be particularly valuable in cases where brain and spinal cord MRIs are normal. If the KFLC index is low, it could prompt you to order mellow antibody testing. Conversely, if the KFLC is 4.9 or greater, it makes MOGAD less likely, even if the MRI doesn't show any specific lesions.
That could save us and our patients all out of time and money, not to mention the stress.
Of waiting for test results.
Exactly. The KFLC index has the potential to streamline the diagnostic process and get patients on the right treatment path faster.
This is great information, but before we get too carried away, I know that all studies have limitations. What should we be aware of with this particular study?
You are absolutely correct. One limitation is that the study was conducted at a single hospital.
That means the findings may not apply to all patient populations. Additionally, the sample size for patients with MOGAD and NMOSD was relatively small, so we need larger studies to confirm these results.
So it's a good first step, but we need more data before we can completely change our practice.
That's right. However, even with these limitations, the findings are compelling enough to warrant further investigation.
I'm eager to hear more about the specific findings. For differentiating MS and NMOSD, let's dig into those details.
Well, let's do that. The study also looked at KFLC index values in relation to MS and NMOSD, which we'll explore further after a short break.
We'll be right back with more insights from this important study. Stay tuned.
The study found that a KFLC index of 6.7 or greater was highly accurate in differentiating MSCI's UC from all other diagnoses, with 95% sensitivity and 86% specificity.
So that means if a patient with ION has a KFLC index above that threshold, there's a very high probability they have MS or clinically isolated syndrome.
Right.
And to be clear for our listener, CICSC refers to patients who present with symptoms suggestive of MS, but don't fully meet the diagnostic criteria at that time.
Correct.
They might convert to MF later on.
Exactly. A significant portion of patients initially diagnosed with CIS later convert to MS.
So a high KFLC index seems to be a good indicator of MS or CICC. What about NMOSD? Was the KFLC index helpful in identifying those patients?
The study found that the KFLC index was less effective in differentiating NMOSD from other diagnoses.
Why do you think that is?
It's likely because NMOSD patients tend to have a higher frequency of elevated KFLC.
So while a low KFLC index points us towards MOGAD, a high index doesn't necessarily mean the patient has NMOSD. We still need to consider other factors.
That's an important point. The KFLC index is a helpful tool, but it doesn't replace our clinical judgment.
Absolutely. Let's get back to the practical implications of these findings for neurologists. How can we use this information to improve patient care?
One key takeaway is that if a patient with ION has a KFLC index of 4.9 or greater, the likelihood of MOGAD is very low, even if their brain and spinal cord MRI findings are normal. This means we might not need to order AMOGA antibody testing in those patients.
That's helpful to know. On the other hand, if the KFLC index is below 4.9, MOGA antibody testing is strongly recommended.
Yes, because a significant percentage of patients with a low KFLC index did have MOGAD in this study. The index can help guide our diagnostic workup. It can also inform our treatment decisions. For example, a patient with ION and a high KFLC index might benefit from starting MS treatment sooner, whereas a patient with a low index might need MOGA-specific therapies.
This is all incredibly valuable information. What are some of the next steps in terms of research?
We need larger multicenter studies to confirm these findings and validate the use of the KFLC index in diverse patient populations. It would also be helpful to investigate the role of the KFLC index in monitoring disease activity and treatment response.
So we need to know if the KFLC index can help us predict how a patient's disease might progress or how they might respond to a specific treatment.
Precisely. There is still much to learn.
While this study focused on ION, it raises the question of whether the KFLC index could be useful for other neurological conditions as well.
That's a great question. While this study doesn't give us the answer, researchers are exploring the potential of the KFLC index in a variety of conditions, including multiple sclerosis relapses, transverse myelitis, and even Alzheimer's disease.
So stay tuned for more exciting developments in this area. Is there anything else you think is important for neurologists to take away from this study?
It's important to remember that the KFLC index is just one tool in our diagnostic arsenal. We always need to consider the patient's individual circumstances, their clinical presentation, and other diagnostic findings.
It's about putting all the pieces of the puzzle together. What a fascinating deep dive. This has given us a lot to think about.
I agree. It's exciting to see how research is leading to new and potentially impactful tools for neurologists.
Thank you for guiding us through this study. I'm sure our listener will find this information incredibly valuable. Let's go back to those patients with ION who have normal brain and spinal cord MRI results. I know that can be a challenging situation because we don't have those typical lesions to help us with the diagnosis.
You're right, those cases can be tricky. The study found that in this group of patients, 30% of those with a KFLC index below 4.9 had positive MAO antibody testing.
So even if the MRI doesn't show us any obvious signs of inflammation, a low KFLC index could still be a clue that we're dealing with MOGAD.
That's a very important takeaway. We can't rule out MOGAD just because the MRI is normal. The KFLC index could give us the information we need to make the right diagnosis.
And on the flip side, if a patient has a normal MRI and a KFLC index of 4.9 or greater, the chance of MOGAD is much lower.
That's correct. In those cases, we can feel more confident focusing our diagnostic efforts on other possibilities. It really shows how the KFLC index can help us be more efficient in our approach.
It sounds like this test could really change how we approach the diagnosis of ION. But I'm wondering about the practical aspects. Is this test widely available?
That's a good question. While the KFLC index is a relatively simple test, it's not yet available everywhere. We may need to advocate for institutions to start offering it. I think as more research emerges and more neurologists become aware of its potential, we'll see greater access to testing.
Another question that comes to mind is how to interpret the results. It's not a simple positive or negative test, right?
You're right. The KFLC index is a continuous variable, so there's a range of values. Interpreting the results requires careful consideration of the patient's clinical presentation and other diagnostic findings. This is where our clinical judgment comes into play.
So the KFLC index is a tool to be used in conjunction with our clinical experience, not a replacement for it.
Exactly. It's all about using all the information available to make the best decision for each individual patient.
This has been an incredibly informative deep dive. I feel like I have a much better understanding of the KFLC index and its potential role in diagnosing ION. What are your final thoughts on this study and what it means for neurologists?
I think this study offers compelling evidence that the KFLC index can be a valuable tool for differentiating between MS-MGAD and NMOSD in patients with ION. It has the potential to streamline our diagnostic process, leading to faster diagnoses and more targeted treatment decisions, which ultimately means better outcomes for our patients.
I'm excited to see how this research continues to evolve and how it will impact our practice in the years to come. Thank you for sharing your expertise with us today.
It was my pleasure. I always enjoy exploring these cutting-edge developments in neurology.
And to our listeners, thank you for joining us for another weekly Neurology Deep Dive. We'll be back next week with another deep dive into the latest neurology research. Until then, keep those brains sharp.